to start with you. Trish, of course, we all know you. You are doing a lot of very famous work. You were writing a famous book about evidence-based medicine. You were advocating for qualitative research methods. And I also learned on Twitter that you were supervising more than 100 PhD students in your life. So I guess you have a very broad overview of different research methods. And that's why I would like to ask you, what is your opinion on the state of primary healthcare and universal health coverage research? Do we actually have too few and too weak research studies, or what do you think?
I think there are some fields where people working within that field continually ask themselves, are we doing enough? Are we doing it right? What is the nature of our existence? Sociologists are always writing articles about what is sociology and, you know, are we doing the right kind of research? Physics doesn't do that. Cardiology doesn't do it, but some disciplines seem quite insecure. And I think the reason why primary care has a bit of an existential crisis about itself and about research is that primary care means so many different things to so many people in so many contexts. And there's lots of different ways of defining and there's lots of different ways of looking at research questions in primary care. That doesn't mean it's a bad thing. I don't think we should be standardizing. Some people are doing quantitative work, some people are doing qualitative, some people, you know, etc. I guess for me, the really exciting areas of research are the highly applied fields. The sort of mismatch between, for example, the Sustainable Development Goals as set out by the United Nations and what is really happening in that clinic in some part of rural South Africa or whatever, where actually the people who wrote those wonderful goals, they've never been to that village, they've never met the people, they don't know what the problems are. But we need, of course, we need high-level research, but actually I think one of the challenges of primary healthcare is how can we do applied research on a small scale in real-world settings, in situations that are completely unique, and still be rigorous and still generate learning. That'll do from me. Soumya's only got half an hour. You should bring her in quick.
Yes, exactly. Thank you very much, Trish, for your statement. And I would like to continue with you, Soumya, because you have half an hour and we are very grateful that you have the time to be with us today. And you are not only a pediatrician and a researcher, but you also served, as we all know, WHO as the chief scientist until last year. And that's why I would like to ask you, after 3 years of leadership experience at WHO, what is your perspective on the state of primary healthcare and universal health coverage research? And what is your opinion? What could be the role of WHO in future in this field?
Thank you, Florian. I think the experience from COVID basically showed us how weak primary healthcare delivery systems were in many countries, paradoxically, especially in the high-income countries, which over the years have focused on tertiary care. And it became clear that, in fact, it was some of the developing countries which had put in place good primary healthcare systems, good community outreach, community health workers, etc., like Vietnam, did a much better job. Now, I think I agree with Trish that primary healthcare research is, well, first of all, there isn't enough of it happening around the world. I've been a strong advocate for it for many, many years. There's, as such, very little implementation research that happens. Governments put in place policies based on some expert opinions, usually, along with multinationals or with local experts. These are usually, top-down, driven top-down. The policy is made. There's a lot of focus on infrastructure, usually, and and other things, but the feedback loop is often missing. And as was also mentioned, what's actually happening on the ground? What are our frontline workers? What are the actual challenges that they face? And what is done with all the data that they collect is often not, that whole loop often doesn't, it's broken. And so what happens is that, I think, to use a term that the Alliance, I think, coined and, champions, a learning health system is what we need, because we need to constantly be not just innovating, but evaluating our innovations. And a good example is digital. Now everyone thinks digital tools are the solution. And yes, of course, these tools make life easy for us, for the healthcare workers, and they can be very good a complement to what the other tools that they have. But hardly anyone is evaluating the impact in terms of health outcomes. If you give iPads or phones to the peripheral healthcare workers and ask them to do digital data entry instead of manual, what sort of impact is that having on improved health outcomes? I think that's what we need to assess. And so just like we would not use a drug or a vaccine without it going through good clinical trials and being validated, we should be thinking the same way about other interventions, digital tools, as well as changes in strategies that the policymakers make in the belief that it's beneficial. But is it really beneficial is something that we need to assess. So I think that particularly after COVID, when we saw the kind of disruptions that happen in primary healthcare, we know now that there isn't enough resilience built into the system. I think that's another important question: is how do you build resilience into a system, whether it's a natural disaster or some other kind of disaster. So yes, I do think that there is a need for mixed methods research, qualitative. I don't think you can do primary healthcare research in a purely quantitative way. You need the qualitative inputs, particularly on the demand side, from the community. And I've been traveling a little bit in India now, and while there have been immense investments being made into primary healthcare, as you know, there's a big program called the Ayushman Bharat program. Clearly, India is so heterogeneous that you need solutions to be tailored also for local. An urban high-density area is very different from a tribal area where there are scattered hamlets, and you might need a different approach to delivery of health services. I'll stop there.
Yeah, thank you very much for your great response. And I would like to ask you, Kumanan, now. We were talking a bit before, because you already focused on health policy research since almost 25 years now as well. And since a few months, you're also the new executive director of the Alliance for Health Policy and Systems Research. And that's why I would like to ask you the same question. What is your opinion on the state of primary healthcare and universal health coverage research? And also, because you were, of course, one of the authors of this report, what has actually changed since the WHO World Health Report in 2008 on primary healthcare?
Well, thanks, Florian. And, it's a real pleasure to join this session. And what an honor to follow Trish and Soumya, who are such leaders. What has changed in 2008? Well, I've got a bit older, but in some ways, everything has changed, hasn't it? Everything has changed. And that perhaps is the reason why we still think we need research around primary healthcare. And Trish made the point, which I think is important, that people still, after 45 years, almost 50 years since Health by the People still argue about what primary healthcare is, right? But I think we can get beyond that, because people still find the approach very useful. Primary care is still the foundation of our health system. So sure, people can have different conceptions, but there is still a need for research. And so clearly we still think research is necessary, because we're still supporting it at the Alliance. So I've only been at the Alliance for a few months, but as you say, the Alliance is also 25 years old. And so we're currently at the moment Robert, who's actually on this call, is leading some work, 46 country case studies, looking at the experience of primary care during COVID in 46 countries in the Southeast Asian region, the Western Pacific region, and the Eastern Mediterranean region. We also have a range of work looking at digitalization and digital interventions in the context of primary healthcare in a number of countries, working with our colleagues in digital health. We're also doing some work around primary healthcare and thinking about its contribution to universal health coverage, although the direction of that relationship is contentious. I'm sure many of your members on your forum have strong views on that. My take on it is that is a little bit echoes what Soumya and Trish said, is that whilst there is a lot of research, there are a number of areas where we still need more work, and particularly policy and implementation research. And I think, as Trish said, to capture that reality of what's actually happening in the clinic for the individual health worker. I'm pleased to say, Trish, that I'm actually one of those perhaps rare people who did work on developing the SDGs. And I was in a clinic in Mitchell Plains in South Africa, in a primary care clinic 2 weeks ago. So I am one of those people who that still goes to clinics. But
I'm impressed.
but I think there, your point is well taken, that we're often behind the practitioners with the research. So there was this very energetic primary care leadership team, 2 young people, and they just went through all the 16 interventions that they're trialing in the context of COVID, where COVID has given everywhere the health sector a lot more visibility, sometimes more resources, opportunities. And so in the Western Cape, under the leadership of Keith Glitter, who's the head of the region, the provincial health department, but at every level, people have taken this time to use innovations. And I do wonder whether sometimes as researchers, we're keeping up with that. I mean, there, of course, the University of the Western Cape and UCT and people like Helen Schneider and Lucy Gilson, they're very much supportive. But overall, I think sometimes, are we doing enough as in the terms of the research to support what people are trying to achieve? I think there are also a number of challenges on key problems that we could do more. And of course, we have people like Trish who are generating research, which is incredibly useful, but it is uneven across the countries that we work with. I mean, Soumya mentioned around the information technology revolution and the potentials of that, but also the risks of that around what does artificial intelligence or machine learning mean, the challenges on disinformation, or on infodemics. I think another thing that we just struggle everywhere to get right is around chronic care service delivery for non-communicable diseases for aging populations. We are really struggling everywhere. I mean, as I told you before, I was moving country families, and I tried to get primary care for myself in 3 high-income countries, and I really struggled to get an appointment in 3 different countries. The health worker crisis, the lack of millions of health workers, the morale of health workers, given how exhausted they are in the context of COVID. I think we're also struggling. I've just come this morning, I've been dipped out of a meeting on the role of national public health agencies in emergency preparedness and response. And I think the role of primary care, and this is what we've tried to capture in these case studies, in terms of emergency preparedness and response, is so important, but sometimes we've seen it be bypassed. So there are a number of key issues which are important for policy and implementation, where research, I think, could contribute a lot more and support those workers in the clinic. And I think that's why we still want to keep doing the research, but we should question ourselves, are we answering the right questions?
Yeah, no, that's fascinating, kind of loads and loads of really great insights. One of the things that your comments really inspired for me is this question of, when does research stop and implementation of research begin? And is that a false dichotomy? I mean, there are some things that are just really so well known that we don't need any more research, and it'd be a really good idea for every pregnant woman to have antenatal care, for example. It would be a really good idea to look after kids in the first 1,000 days, whatever it might be. We don't need to do more research to refine those basic insights, but we do need to look at how people go about doing stuff. I'm trying to avoid using the word implementation, because I was in Sweden recently and there's a group of really good quality improvement people. I said, will you stop using the word implementation, because it creates this false distinction between research that gets done by university people like me and doing things. And actually, I think we could learn a bit from the software engineers, where the software engineers just kind of develop something and then iterate it in the real world, fail early, fail often, try it out, plan, do, check, act, those kind of cycles of improvement. And whether or not that counts as research, my students get tied in knots about this, because do I need to get research ethics committee? And I say, research ethics committee approval. And I say, well, you need to be ethical, but whether or not this particular piece of action in the real world is research or not, we can go round and round with that. But I think, I've been in research now for about 35 years, and I'm much more interested in, as I say, what's going on at the coalface, whether you call it research, whether you call it implementation, whether you call it quality improvement, whether you call it innovation. And I think we need to study that, and that means that actually that people in big national organizations, big senior positions can help a little bit. But I'm so pleased that you were out there in that village, in that frontline health center, because actually people in those places are often as clever as we are. They're doing creative things. They know more about their community than we do, and we need to kind of be democratic about sharing our mutual knowledge.
Yeah, thank you a lot for your comment. And I would then like to continue with the next question. My question would be, we already know a lot about primary healthcare, but why do we actually then need more research on primary healthcare? And if we need more research on primary healthcare, which kind of research, or which research methods, or which research questions do we actually need?
Mm-hmm. Yeah, that's a great question. And I suppose one could go into a lot of details on the kinds, but I think just building on, what also Kumanan was saying, obviously populations are facing new challenges all the time, right? And because in most developing countries, health systems have been focused on infectious diseases and maternal and child health, almost to the exclusion of anything else, we suddenly find ourselves in a situation where the NCD burden has grown considerably and it's crept up upon us. And suddenly we're finding huge numbers of people, premature mortality and morbidity. And all of that needs very expensive treatment. You need dialysis and you need, stents and cardiac surgery and stroke rehabilitation. And it came upon us, while we were still in the MDG era, and most of the funding was going to MCH and infectious diseases. And in fact, it still does. So I think one of the things that probably we need to pay more attention to is analyzing what proportion of funds are going to primary healthcare versus secondary or tertiary healthcare in a country's budget from the national health accounts. And within primary healthcare, what proportion is going to the diseases that are causing the most burden. So very few countries are actually allocating based on their disease burden. And I know that when I was in India, the ICMRB did the first state-level disease burden estimation along with IHME. And it came as a wake-up call actually to most states when they actually saw how the proportion of diseases that cause their main public health burden. So I think that is something that we need to be looking at, which can definitely feed back into policy. The other thing is health technology assessments are still not a part of many decision-making processes within ministries. And again, I think there's good examples from countries. Obviously, Thailand has been one of the leaders there, but India also has now put in place a robust health technology assessment group within the center, but also in every state. So I think there are 18 or 20 states now that actually have the health technology assessment function or a group that's been set up that is responsive to questions that are coming from the policymakers. and then I'm doing the analysis and providing that input. So that's another kind of very practical function that that we probably need to build. And I think, just the use of data that's collected routinely. I think we're underusing the data. We make our frontline workers collect loads of data, but how much of that is actually analyzed and used to make policy decisions, or used to train or retrain or mentor the frontline health workers? And I think that that's an area today, particularly with digital data collection and the ability to analyze large volumes of data. We need those functions which are often missing within health ministries, of people who are able to analyze large volumes of data, synthesize, and then make some, some sensible conclusions from those. So I think those are just from my own observations, some areas where we probably need also more capacity building, and you need, more multidisciplinary teams. Finally, I would say social and behavioral research, very much neglected. Very few ministries have, let alone a whole group. I think very few of them even have any experts in behavioral science. And we saw during the COVID, especially when behavior change is needed, and many public health programs, do need behavior change, particularly when we're talking about non-communicable diseases. So without that insight into what drives behavior change and how that can be, most usefully done, and the community engagement that it needs, I think those elements also need a lot more emphasis. I mean, every time I was in a tribal area last week, I sat down with the community members, with women in the community, but also with the frontline workers. And, spend a couple of hours there and you understand issues that could be set right, but it means that you first have to listen, and then you have to think of solutions to the problems. So it's doable, but it just needs time. And again, it doesn't have to be done in research mode. I think I agree with Kumanan that, we can just, and there's a thin line anyway between sort of doing action research or collecting data and using it, wisely. Yeah. I think that needs to be built into the system.
Yeah, maybe if I can add then, I think you asked two questions there, Florian. Firstly, was that, are we sure that primary healthcare is the foundation for achieving UHC? Do we know enough to be clear on that? And then secondly, well, then what more research, which is continuing this conversation. And I agree with as I always do with what Soumya says. I think for the first question, I mean, is that an evidence question, or is that a sort of paradigm question about how you see the organization of health systems, right? And there are many people who are uncomfortable about the idea that UHC is the dominant paradigm, and certainly my friends at the People's Health Movement would say that UHC sort of loses some of the aspects of primary healthcare as an approach to health systems, which is as health as a human right, care delivered close to where people live, the strong sense of communities and people as actors, as their own agents for their own health, and involvement in the governance of health systems, and of course the need for multi-sectoral action on all the features that create and destroy health, many of which lie beyond direct health care. I'm not sure whether, obviously, I think from a WHO perspective, it's that UHC is a goal. It's there, that everybody has access to high quality healthcare at an affordable cost when they need it, right? And then primary healthcare is an approach to the structuring of health systems and delivery of healthcare, as well as addressing determinants, which helps us to realize the right to health. So I think the sort of debate is probably not so helpful. But I think just from a normative sense, we probably do have enough evidence to say that primary care is the essence and the foundation of health systems. We probably could do with more studies. I mean, we often refer to the same old studies to make that claim. I mean, Barbara Starfield and the work that she did, looking at the difference between states in the US. I remember when we did the World Health Report in 2008. I mean, I think actually a sort of strengthening of that evidence, particularly in some of the lower middle income countries, to make the case for primary care would probably be still useful. So that's one area of research. I think for Trish, you know, the Alliance has always been very much at that nexus and interface between evidence and information and research and policy and practice. And yeah, we have these great opaque terms like embedded implementation research, which is really where you transfer the power to set the questions and drive the research to, and sorry, Trish, we still do use the phrase implementers, so apologies to our Nordic friends. And that's really just saying that, yes, it shouldn't be either or, and you should be doing research in live systems, addressing live problems, and therefore, you know, researchers have tools, they have rigor, they have methodology, but they should be supporting the practitioners, communities, people who know what their problems are and answering their questions. And so we'll continue to do that. And it's not just the Alliance. I mean, I used to be at UNICEF and we work with the Alliance on this, and a number of partners around WHO, the World Bank, etc. One thing I do worry, though, is whether we have a very static concept of primary healthcare. So on the one hand, I think we aren't historical enough. And I always joke that when I worked with the World Health Report as the junior author, I went to all the archives and read all the documents from the 70s and 80s. And I used to joke, we can cut and paste this and just put it back and everyone will think this is really great. But on the other hand, I mean, things like continuity of care, which is one of our shibboleths, for a Generation Z who are used to sort of accessing things on their phone, and that's everywhere, not just in high-income countries, and just want the solution and don't necessarily want to go anywhere, are they as invested in the same practitioner and the same clinic? Are we prepared to question those things? And so I think those are areas for research. What do we do about this health worker crisis? I mean, we keep saying there's a big push in many countries that have non-medical led primary care services that have been very successful, that people increasingly want doctors, whatever we say about the evidence and the evidence on task shifting and in terms of quality. I worked a lot on integrated community case management when I was at UNICEF. Obviously, you can deliver interventions. So what are we doing about that? Are we really engaging with task shifting? Are we understanding how might that work? The issue around the navigation function of primary care, which is so essential. And that just doesn't work in so many of our systems. One of the exciting things in the Western Cape is that they're now, when people get discharged from hospital, they're pushing alerts to the primary care facility, to the health workers, so they know someone has gone back in the community and then they're following them up. That's an interesting use of technology. But are we really sort of doing research that can make use of the technology to understand those types of functions in primary healthcare? I think overall, we always say, oh, well, the problem with primary healthcare is we haven't implemented it properly, and that's why we're not getting the gains in terms of health equity, in terms of realizing the right to health for more people. But I think that, and one of the things we're trying to do at the Alliance is say, okay, well, what is the research agenda for primary healthcare? And I spoke to you about some of those things, but there's lots more to do. And it's great then the network that you have, 500 people, really can contribute. And I think that we can't just assert the importance of primary healthcare and primary care. We still need to demonstrate it, and then we need to respond and help solve problems in the delivery of primary care. And research needs to be serving those needs rather than an end in itself.
Shall I come in there? Yeah, this is really interesting. I've just been writing down the key things that you both said, and I couldn't agree more. So this is what I've got from this so far: burden of disease, health technology assessment, use of routine data, which is currently underused. So the sort of learning health system type models. And I know when I was on stack for the Alliance, there was some really interesting work around learning health systems, social and behavioral research, workforce research. It's always slips off the agenda, that one, doesn't it? But how do we get the skill mix right? And yes, I know people want to see a doctor, but usually when they've seen another health professional and been well cared for, they stop wanting to see the doctor. So I don't think that should stop us. There was something about values. I totally agree that the universal healthcare is a values-driven concept. It's about what we feel about what kind of society we should live in. And then there's all those questions around, if you like to use the I word, implementation. And the only thing, so that's what you've already said. I suppose the one thing I would add to that is, and this is a sort of meta question, is how much of any research can we say this is a general finding? We've done the research here, but it's valid everywhere. So we say, for example, that primary healthcare strengthens health systems. Is that always the case? I probably think it is, but maybe that's my biases. I think we need more research into the particular. I did some research. I've always been interested in something I call transition zones, parts of low-income countries that are becoming economically more wealthy, and then you sort of draw in people who are looking for jobs, and some people do really well there, but actually around the outside of those transition zones you get very high rates of things like childhood obesity, type 2 diabetes, all those kind of things. So I think the idea of kind of saying, well, we want to do research into, for example, the double diseases in particular settings. And I'm thinking back to Hans Rosling, who would say, look, if you take China, Shanghai is a very different country from some places out there in the rural areas. And I think we need to be, we need to be a bit more granular, I suppose, with what we're doing.
Yeah, if I can, I mean, maybe, I think, again, it'd be great to open it up. I think Soumya has had to leave. But I think that point about the granular and the particular, right, is that in the world, really is it the job of us to sort of set templates? And so this is the tension. Yes, it is helpful to understand generally what is useful and what is applicable. And yet the sort of idiosyncratic natures of health systems, not just between countries, but even between different settings in countries, just is even more apparent, right? And so again, I think it's about saying, well, how is this supporting decision makers, practitioners, communities in specific settings? How does our research work? And we should still aim for some sort of generalizability, but a lot of the work that we at the Alliance do is on the particular, because we think that is especially useful. And I think COVID has shown this, right? I mean, if you think, well, outbreak management is a relatively standardized thing compared to some of the other things we do in primary care. And yet, even then, if you look at the heterogeneity of country responses and what drove that, I mean, that also shows the limitations of evidence and research, right? It is about politics. It is about values. It is about the nature of societies. And so I think as the research needs to engage with those realities much more strongly to be useful, not just to say the research sits outside of that and then we can apply it. And I think that, in the chat, we have a discussion around the differences between chronic care and acute episode care. So I think that's well recognized. We've been talking about that for a very long time. And yet, perhaps we have struggled to engage with the particularities of health systems in terms of health workers, in terms of skill sets, but also community expectations, the ability of commodities. And so we really are struggling, and not just low and middle income countries. I mean, so many high income countries are increasingly in crisis with trying to deal with these complex needs, right? I think the other area, I mean, you mentioned learning health systems, and yes, my colleague Kabir Sheikh leads the work. There was an Alliance flagship report on learning systems. And I suppose the question then is, how do we make that a reality? Because no one disagrees with the idea of a learning system, the idea of a system that through practice can learn from errors, can sort of diffuse practices at work in one part of the system across it. But in reality, people really struggle with this. When you're sitting doing your very long shift with so many patients, what is your capacity to sort of be able to, this is what I found so inspiring in the Western Cape, that this was a very challenging place to work, and yet they were so upfront about the innovations, they were testing things, but not every health worker is supported to do that. And so I think going forward, I'm sure at every anniversary of Almirata, we all have a conference, we do a new report, and we say how important primary healthcare is. But I think we need to be more accountable at global, at national, at district levels for saying, well, have we managed to get these principles in place in our health systems? Are we genuinely sort of respecting the agency of people? I think those principles apply whatever we're doing. real sort of focus on health equity, like who's doing well out of the system, who's not doing well out of the system. And so I think that research can always help inform those questions, because the world, as we said, 2008 was only 15 years ago, and the world has changed geopolitically, technologically. We live in this world of these interlinked crises. Fiscal space for health is really worrying. If you look at the data about what's happening to health budgets globally, it's extremely concerning. Mike Ryan this morning, who heads the emergencies program at WHO, as probably most of you know, was pointing out that the sort of concern of CEOs on health and outbreaks and pandemics has gone from sort of number 1 about a year ago to like number 24 or number 27 now. Right? People just want to get on with their lives. There's a feeling that health has had enough attention. We've got to do other things. So health systems, which are exhausted, health workers are exhausted, really stretched, they're going to have a really tough time in the next few years. And so then the question is, well, what does research have to contribute to those problems? And I think that's the sort of work we're trying to support at the Alliance, is to say that, yes, we believe primary healthcare is the approach towards health equity and health systems, towards universal health coverage, but beyond that even, and primary healthcare also looks at determinants, at least in a proximal sense. How can our sort of policy and systems research support the world to improve the delivery of primary care? Yes, but also so that a primary healthcare approach is sustainable and can help people to manage these crises and these challenges that they're facing. I think that is the challenge we face, but I think more generally for primary healthcare research, that is the challenge.
Yeah, thank you a lot for this very brilliant, very interesting discussion. And now I would also like to ask the participants.
Thank you. Thank you, colleagues. It's Amanda Howe here from the UK. I was very involved with World Organization of Family Doctors and interface with WHO there. Having been in primary care myself as a clinician and in academic life as a researcher, I guess that you mentioned the capacity word, and that's one issue. I think, if I'm in my clinic and I'm recording, my administrators are recording how many patients have come in, they're loading data, what the main diagnoses were, if they had to send to the hospital, whether it's for fee collection or insurance or just because that's how we do it, that's one thing. If they don't have that easy way to upload data while they're working, we lack something. Second level, and Trish knows this probably better than me, if you then have a national set of databases that bring together, consultation data, profile of the workforce, numbers of referrals, then researchers can get hold of those databases and start to interrogate them. Then you have to have the capacities for the researchers to do that. So I remember when we had primary care trusts who collected data and would feed back and say, oh, this is an outlier, and this is interesting. Why have we got this pattern in your community? And I might have some academic trainees here who I could give a small project and get agreement locally. But if you don't have those researchers, even local level or national level, whose job is to interrogate primary care data and to support primary care research, then nothing happens. And I think many countries, and indeed like mine, have a real bias in the research world according to who funds it and what they are prepared to fund. So even in the UK, where we've had, reasonably strong and some great leaders in academic primary care, we still see that the bulk of the budget is either funded from pharmaceutical companies or new technology companies. So it's either commercially funded, although we have ethical ways to try and manage that, or it's more lab to bedside, it's acute sector, it's bioscience, and all the big growth in my region where I work in the past 10, 20 years has been in bioscience and the, pharmaceutical technology. So I think there's a system bias against primary care research and capacity building. And that will be an even bigger challenge in some of the countries who have less academic capacity and less funding perhaps than the UK. And so forgive me, but some of my experience with WHO is There's a lot of saying what needs to happen. But actually, I know the country representatives go out and they've got thousands of things on their agenda and they can't fix their own systems. And possibly the last thing they do is come back and say to their governments, do you know what? We need to have a primary care research unit in every university, working together as a network to actually drill down into what is happening on the ground and then to evaluate implementation and innovation.
Can I respond to that? I love hearing you, Amanda. I haven't heard you going on about how passionate you are about primary care research for a while, and it's lovely to hear you again. You said the capacity word, and I think one of the things that the Alliance does is, because I sat on that group for 4 or 5 years, they do an awful lot of that capacity building in country.
Indeed,
and,
yes.
You know,
No
I think it's a great model. It's a fantastic, it really sort of changed the way I thought about research. But I was going to say, we've got to be careful not to scare people. Because if you're not careful, you think, if you don't have a national database or a regional database, and if you don't have a PhD, and if you don't have 10 people working for you crunching the numbers, then you can't do anything. I think we need to build a little bit of capacity everywhere. Every single person who works in healthcare ought to be able to reflect on the kind of data that they've got in front of them, the kind of data that they need. They ought to be able to collect data. They ought to be able to make a judgment about whether they trust those data, and they may be qualitative or quantitative. And they need to be able to go through that cycle of asking a question, collecting data, analyzing it, and improving. Now, you could say that's not research, but actually the skills you need to do a good bit of audit, a good continuous quality improvement cycle, are the same skills that you need to do research. And actually a tiny little bit of that kind of training goes a long way. And I just remember back to that very first time when I was a new GP and one of my patients with diabetes had a stroke, and I thought, crikey, they were only 45. What on earth happened? And I did an audit with this rudimentary computer system, and I discovered that half my diabetic patients hadn't had their blood pressure checked in the last however long it was. And so I wrote them all letters, and people came in and got treated. So it was a really basic piece of audit using skills of just, you know, searching a database, looking for a particular coded piece of data, all that kind of thing. And actually, I could teach someone to do that in half an hour. So although, yes, we need HTA, yes, we need all this really ivory tower type research, we also need to build the capacity and the motivation and the protected time among frontline health workers to evaluate what's going on and to be driven by their own clinical curiosity, because you can save lives doing that.
And I think, you know, I think the point is well taken, Amanda, and thank you for that intervention. But I do agree with Trish in that one of the challenges is also just demystifying research, because people have this idea, they don't see themselves as people who can do research, because often academic institutions themselves have this very sense that that is where research occurs. And one of the things we've tried to do at the Alliance is to really bring this sense and support countries so that people feel they can do research in their own systems and solve problems that they're having, and that it doesn't require like a large cluster randomized control trial for millions of dollars. Exactly. That for actually quite small amounts of resources you can do work. One thing that, so for example, again, I'm not trying to debunk people's perceptions of what people in global health do, but when I was in the Cambodia WHO office, we worked with the Alliance. With a small amount of money, we supported a team in the National Institute of Public Health in Cambodia who were already sort of working on health policy and systems research. And then they were able to, they're sort of doing a range of work from NCD service delivery models, looking at some of the data. I think the data point you make is very important, that we really have done a bad job of improving data systems. And in so many places it's very hard to sort of integrate that data. And so that means that's a real problem for primary care if you can't follow people through a system. A lot of countries don't even have a unique identifier, or they therefore are not able to generate those audits, which, as you say, can then generate the ability for people to do sort of practical, simple research. So I think I hear that, but certainly that, I mean, I think the other point I'd say is that one of the things that has improved, I've seen over the course of my career, and I think you've all probably seen, is that actually the training or people who have methods training exists in most settings. The problem, as you say, is that the funding isn't there to do the research, because we know that clinical research gets the bulk of the research, or sort of very traditional clinical research, and there's not so much research funding for health systems research or individual researchers. Even if they train, then there aren't sort of roles for them. And so I think that's, again, one of the things, as Trish said, the Alliance tries to do, is to provide, small amounts of support so people who have those skills can then deploy them. Because I'm always impressed wherever I go, just how many smart people there are who have research training, often working in systems, who want to do things, but just lack the resources to take that forward.
Thank you a lot again for the brilliant discussion. And Soumya also had a comment or a question.
I just wanted to follow up on what Amanda said, because a lot of the things that have been said so far would make a big difference if there were more academic units of primary care. So let me just tell you, my experience in Zimbabwe was that the medical students used to go to rural or townships every year for the 5-year training. Every year they did community-based education programs. And in their 5th year, that meant them doing a clinical audit. But because the people who were supervising them in the district hospitals didn't have much capacity to supervise them from a research point of view, just doing simple audits, those audits, even though they were educational, they weren't rigorous enough for them to publish. So quite often they would lose motivation around it. I would get a lot of people, I worked in public health at the university there, I used to get a lot of people asking me, to help them write it up. But if the original design wasn't good enough, it's very difficult to do that, though they completely understood the concept of doing audits. And so having a unit, I asked this question last time with Michael Marmot, how do we raise the status of primary care from all these different aspects in low-income countries? Because very few people go on to become specialists in primary care. It's improving in Africa with family medicine. And I'd like to say that a lot of the advances in the Western Cape that Kumanan has talked about are because they've got universities with family medicine departments where students are doing postgraduate specialization. They have to do research as part of their work. All of this has an impact on the kinds of care that is given at the front line. So it isn't, doing a bit of this or doing a bit of that, having it fit together. So community-oriented primary care, an understanding of a population base, working with public health to define the disease burden, extending the team beyond the facility, i.e. into the community. All of these things fit together. And when you get that fitting together, then you get good work being done that can be evaluated. But if you don't have it and you have lots of little bits of it, then it's very difficult to pull it together. Even the data is collected on a daily basis in primary care clinics. It goes to the ministry. There's very little feedback. It's almost impossible to use it for planning purposes at the primary care level. I think having academic units would make a huge sense, but unless it has status, unless WHO pushes for this, or whatever big bodies there are who could push for this, it won't happen. And then we'll be 20 years still asking the same question. Does primary care really make a difference?
Yeah, no, this is really interesting, but also slightly depressing in that people, I get the idea that when you do research, you want to publish it, because the whole point about research is that you're doing something which then has an implication for others. But if you look at I've been reading a lot of pragmatist philosophy recently, and pragmatist kind of social change. And the idea is that when you measure things, when you collect data, you're doing it primarily to do something ethical locally. And you might write it up, and trying to remember the name of the woman who won a Nobel Prize for doing this kind of thing, but in America about 100 years ago. But we have to make sure that we're not letting the tail wag the dog here, because the reason why we collect and analyze data is to be able to serve our communities better. And publishing is just a kind of side issue to that, or it's a means to that end. And I've sat on more national committees about research impact than I care to remember. And I think research needs to get its house in order to take away the perverse incentives. And, you know, a good piece of data analysis, data collection, data analysis with a good piece of implementation locally is worth far more than a publication in the New England Journal of Medicine that nobody reads, or that doesn't actually change anything. And I think we researchers, the research community, is guilty of producing some distorted values. So I think we need to make sure that the moral narrative that accompanies this capacity building and research is centered on our commitment to our communities, rather than some airy-fairy idea that everybody needs to write an academic publication.
Yeah, and to music to my ears, Trish. I mean, 2 final points. But I do understand what you're saying, Sunanda, in terms of, I understand that the importance of publication in people's career paths and the ability to continue doing work in many systems. But I think that, you know, probably publishing is one of those things that really needs disruption and those perverse incentives, as you say. I mean, a paper is a tool, but if the only aim of research is a paper, we are losing something. And I mean, I take your point again, Sunanda. I mean, in the University of Western Cape, you do have, well, the sort of influence and legacy of people like, well, still there, Helen Schneider, Lucy Gilson, David Sanders, obviously, who's not with us anymore. And I mean, I saw in Mitchell's Plains, Trish, the district manager started off with a presentation with the framework of health systems, and they described their work in terms of that framework, which I had not seen before. But that was very much the sort of legacy of and the influence of Lucy. So I think your point about the importance of having these academic units, as long as they're fully engaged with the practitioners, that's the magic when you bring those together. And academics units, you have people with both those skills, hopefully. But I think also for us, I mean, when you look at the proliferation of academic journals and academic papers being published, and then, I mean, I haven't met so many district managers or ministers who spend a lot of time reading papers, although, you know, there are journal clubs. And so I think it's also, again, about that learning system and what are the modalities that we can use to transfer knowledge. And so people can, with this work they do, with the data, with the analysis, the research, can influence change. And there, I think the technology is promising, but we haven't quite worked out how to make that work best in a practical way. The last thing I just wanted to say is also about the location of primary care. I think this is one other research question in terms of not just seeing health systems as existing outside of people's homes. And certainly with COVID and with the technology, we have seen the ability of people that more and more things can happen in the home. And how is primary healthcare considering that? It's again that navigation function. Primary care should ensure you get the care you need where it is most equitable and efficient and convenient for you to get it. And so, you know, just reflections on all the people who can now do home testing for infectious diseases, which was just thought of as unthinkable 3 years ago, right? So that's another sort of area that I just wanted to highlight before we finish for research around primary healthcare, thinking about how that fits and again supports people's agency for their own health.
Yeah, thank you very much for this really, really great discussion. Unfortunately, I have to close now because I also want to respect the time of the panelists, of course. And in this way, I want to say thank you to all the panelists, Trish, Soumya, and Kumanan, of course, It was really, really great to have you, and it was a really brilliant debate and discussion.